Hi everyone, so my name's Fred van Someren. I'm a junior doctor who works in the east of England at the Lister. I'm here presenting our project I've done with Helen, who's an epidemiologist who works at the London School of Hygiene and Tropical Medicine, and some co-authors on the other slide, looking at the distribution of high-cost narcolepsy drugs across England. So just to say that Helen has a NHR fellowship, and this is a list of co-authors, including Milan, who is here today, and then the rest of our collaborators are a range of epidemiologists and clinicians. So for those who aren't aware, narcolepsy is a chronic, quite uncommon neurological condition which is characterized by predominantly sleep-related issues, so excessive daytime somnolence, sleep disruption, and cataplexy in type 1 narcolepsy. For many patients, there's quite significant difficulty in attaining a diagnosis, and once diagnosed, there are limited treatments specifically in particular for excessive daytime somnolence. So first-line treatments are generally amphetamine derivatives, which are relatively cheap. But for patients who fail with this treatment, there are a range of newer, higher-cost treatments, but as we'll come on to explore, there's limited ways of access to this. So the three drugs that we're looking at in particular are pitolisant, solriamfetol, and sodium oxybate, which I've put in bold because it also has the added benefit of also helping to treat cataplexy. So for patients with narcolepsy, there's a lot of barriers to attaining sort of a reasonable level of care. There's difficulty in attaining their diagnosis. There's a limited number of treatment centres and clinicians who manage these patients. And there's no standardised funding pathway for these treatments. So patients who are put forward for higher cost treatments are exposed to a range of different mechanisms by which they can attain these treatments. Our suspicion, and as is reported by patient groups, is that there's variability in management of their care between different regions and different funders. And the last thing we just want to touch on is the fact that there are new, probably more expensive treatments that are going to become available for narcolepsy in the next few years, and understanding how that's going to fit into how that's going to be managed in the current setup that we have for narcolepsy care. So currently, higher cost drugs for narcolepsy, as touched on, we have sodium oxybate, pitolisant, and solriamfetol, and they're all licensed in different ways. So sodium oxybate is funded by NHS England for children, but not for adults. Pitolisant has been reviewed by NICE, but not approved, and solriamfetol quite recently gained NICE approval in 2022, but there's still restriction and in our data set, quite limited uptake at the time of our analysis. As a result, there's quite a significant variation in decision-making processes by ICBs and by individual trust levels as to which patients are funded and who can receive these treatments. So when we set out this project, there was quite a few different things we wanted to look at. So what is the current prescribing landscape for high-cost drugs in narcolepsy? So who is getting these treatments and where are they being issued? How has this issuance changed over time, and how does this vary by geography and by ICB? And then sort of leading on from that, what might the potential implications of this be for newer treatments? And then as a sort of secondary objective, which we didn't really explore in the paper, but I think has relevance obviously today, is understanding how large data sets and clinical prescribing data can be used to understand rarer and underserved conditions which affect a minority of patients across the country. So as a broad overview, our project sort of took this approach in that we took data from the England prescribing data set and the secondary care medicines database. We brought that all together and sort of analysed it to look at drug prescriptions per primary care practice and and hospital pharmacy stock data, and then use that to describe the distribution of and the trends that we see in these medications across different ICBs and across different regions in the country. A slightly more detailed breakdown, just to go through how we sort of set about this, and this is essentially how as I understand it, at least open prescribing hospitals works, is that we first looked at took the specific codes for each of the medications we were interested in looking at. We collaborated with some of the team here from the Bennett Institute and were given some initial data, which we then expanded and combined into one complete data set. This was then all converted into defined daily doses and then mapped to ICBs in geographical regions using publicly available data from NHS Digital. And as a result, we've ended up with a sort of our descriptive analysis of primary and secondary care drug issuance of high-cost drugs used in narcolepsy between 2019 and 2022. And if that all sort of made sense, you might notice this is a very similar in idea project to that which Ola presented earlier, essentially along the same lines, but looking at narcolepsy drugs instead. So what did we find? So what we did see, somewhat reassuringly, is over this period of time, there was evidence that patients had increased access to these higher cost drugs. So there was almost a 50% increase in defined daily doses of these drugs issued in 2022 compared to 2019, majority of which were sodium oxybate or pitolisant with a tiny small amount of Someren introduced. Perhaps slightly less reassuringly though, less than a quarter of these medications are being issued in primary care. So the bulk of care these patients are receiving is still being led out of a secondary care trust. And similarly, a majority of these medications are being issued in only 3 integrated care boards. So, and on top of that, we saw that there was a significant variation between regions and between ICBs, suggesting that there is potential difficulties for patients in accessing these treatments and gaining the care they need. So this figure has projected quite well. So here we just see that starting in 2019, this is just a plot of 3-month rolling averages of the number of DDDs issued. And we see that these 2 lines are secondary care issuance of sodium oxybate and pitolisant, which has increased nicely over the period, but markedly smaller increases in primary care for both sodium oxybate and pitolisant, so roughly equal amounts across the data period. These figures show the top 15 ICBs by issuance of all DDDs in 2019 on the left and 2022 on the right. So we see that, as touched upon, 3 ICBs contribute to a significant proportion of all of the DDDs issuing, and there is other high proportion ICBs that feature in both year groups. But obviously this only accounts for 15 out of the 42 ICBs, so as we get down the graph we see increasingly smaller and smaller proportions and amounts of DDDs being issued for patients. This plot is demonstrating the total amount of DDDs issued in primary care and secondary care across the whole data period mapped to the ICB regions. And so these are both logarithmic scales. So whilst on the left it looks like there's a good coverage, most of these regions in yellow suggest that very small amounts of DDDs are being issued in primary care in these areas, and actually suggests that in large areas of the country there's very little access for patients with narcolepsy to receive these treatments from their GP. Whereas conversely, we see in the secondary care level, we have several high-hitting areas, as we've touched on before, but also lots of areas where there's essentially no secondary care issuance, suggesting that patients are effectively having to travel out of area or travel to specialist centres in order to receive secondary care. And finally, just to touch upon sort of a regional breakdown. So we see sort of almost an inverse pattern that we have some geographical regions where actually there is quite good issuance of sodium oxybate in particular in primary care, and smaller amounts issued in secondary care. So in the Midlands and East England, these numbers benefit from the fact that Leicester and Papworth hospitals Papworth Hospital in Cambridge have these established shared care pathways which help to facilitate issuance of the more expensive sodium oxybate in primary care. Conversely, as touched on before, obviously we see that the regions which have these heavier hitting ICBs where there's higher levels of issuance, so London, in South East London and the North East, have very high volumes of drug issuance in secondary care. So in summary, we see that there's quite a significant variation in issuance of high-cost drugs, and the bulk of the majority of issuance is within these 3 ICBs. There are several regions where there's very low or no issuance of higher cost drugs, and there's a variability between primary and secondary care issuance within higher issuance ICBs and regions. This sort of reflects what we had anticipated in terms of the varied means of access to care and funding for higher cost drugs across the ICBs, and similarly reflects the lack of national guidance and standardised care for patients with narcolepsy. Perhaps concerningly, in terms of the plans to sort of try and move particularly neurology care, more into the community as part of the 10-year plan, significant amounts of these medications are still issued in secondary care. And as mentioned previously, this in turn will have implications for the newer treatments, the orexin agonists of varenicline and alixorexton. The anticipated cost of these medications is, well, the market value suggested in the US is they'll be over $250,000 a year per patient. That's only slightly more than it is for sodium oxybate. So obviously there will be probably only being introduced with an NHS subsidy. But there needs to be sort of a greater understanding of how these services work to understand how we will be able to fit these new high-cost treatments into the current paradigm. And finally, just to touch upon the use of clinical medicines data. So I think most of this has already been covered by other people, to be honest, in their talks. But I think that our study sort of is kind of a good example of how this sort of data can be used as a descriptive analysis for for rarer conditions or underserved conditions where there is no sort of national database or way of analysing who is receiving what treatment where, and which services are providing those treatments. I think that also, obviously, the benefits of having this open source data is that it allows relatively straightforward analysis of these medications and of these of rare conditions. There are some limitations, again, which I think have mostly been touched upon already. This is trust level data. It's not individualized. We can't pick apart the indications, but the benefit here is that most of these medications are almost exclusively used to treat narcolepsy, but that doesn't mean we can't compare to the first-line treatments, which are more generalized. And we don't have a true denominator here for analysis, because the anticipation is that the vast majority of patients do have to move out of area to receive their specialist care. It's also just worth commenting that at the time that we pulled the data, there was a low level of missing data or data from trust that wasn't fully reported. So yeah, that's just a QR code link to the paper. I'm happy to take any questions.